Thank you for joining us. As I said, my name is Sabina Chacheva. I'm the program manager here at the Cancer Wellness Center. For those of you new to the center, the center is a nonprofit that offers free support, wellness, and education to those diagnosed with cancer and their loved ones. As I mentioned, this program will be recorded tonight, so please feel free to submit your questions through the chat box. Now, without further ado, I'd like to welcome our presenter this evening, Dr. Alfonso Tafor.
Thank you very much. I think you can hear me, and it's nice to be back to the Cancer Wellness Center. You've been kind enough to host us also every so often with the PACO Foundation, in which we continue to give education to patients who have a history of blood clotting or are at risk of it, which is really what I do. So I'm a vascular medicine physician, and what that means is I like blood vessels. But within that, actually, I train at Mayo Clinic, and then I went deeper into blood vessels in the fellowship there. And then in a master's degree, I actually went deeper into cancer thrombosis and moreover in risk prediction. So that's what I really enjoy, pretending I can predict the future just to find out I can't. But that's why this topic is of interest to me, because it goes to the trajectory of cancer thrombosis. Why is it different? And how do we move the dial from treatment only to preventing also, and to modify the options that we have during treatment? Now, I'm going to go ahead and guess that for many of you, this topic already resonates some bells. But nonetheless, I will invite you actually to try to make this as more interactive as feasible, and aggressively use the chat box in a few seconds. I'm compelled to say this. I mean, there's some research sponsoring that I have received directly or indirectly, and some of that actually was in cancer thrombosis research as well. Nonetheless. So where to start? And this is where I'm going to go to 3, 2, 1, go. And go ahead and if, depending on which browser you have, you may see a chat box function at the bottom or a chat box, a chat function in the on the upper part. And I'm curious about which may be the questions that you have about thrombosis or not. So, you can read some out loud if there's any, but I would be really interested in learning more about where we are starting, so where we're at right now. Any takers on that? So,
feel free to submit those through the chat, as Dr. Tafor mentioned.
That's going to help us also direct where to go a little bit, I think. We all start in different place, and it may well be that you know somebody already who has had a blood clot, and it may always be actually that the blood clot concept itself is not as well understood. Nonetheless, I'll want you to please go ahead and throw the questions during the interview, during the lecture, so that way we can actually move back and forward to a more interactive Q&A here. So this is what I'm going to talk about a little bit. So prevention from cats and cancer-associated thrombosis. So let me start with the basic. I mean, what is a blood clot? More often than not, in the legs, we have the veins, the arteries, the lymphatics. And the cancer cell is going to be smart enough as to change the environment. And it will change the environment on the platelets. So you can see them over there. They will become a bit more aggressive. Chemotherapy in itself, some more than others, but we're not smart enough to know which ones are worse, will affect the clotting cascade, will affect the endothelium, meaning the innermost layer here of the blood vessel, and eventually activate the inflammatory cascade so that blood clots start happening. So imagine blood clots as jello, almost melting jello. So it's sitting inside your vein, but it's smooshy enough that it can dislodge, travel. And that's where the bigger problem begins, because once it can travel, it will travel to places including your lungs, through the heart into your lungs. And that's a potentially fatal event. And even if it wasn't, it's going to need anticoagulation, it's going to delay chemotherapy, it's going to make the patient feel worse. And as I'm going to start explaining, it is also an indicator of how poorly the disease may actually progress as well. So therefore this one. So imagine I have a town and the whole town is mine. It has 26,000 people. And those 26,000 people, I'm going to follow them. It's my town, so I'm going to register them all into a single database. I'm going to follow them in time, about 10 years actually. And throughout those 10 years, I'm going to figure out who developed cancer, who developed blood clotting, who got them worse, got them both things at the same time. And of course, the study actually looked into many other things. This was the Thrombosis study, and this follow-up ended after about 10 years of continuity. And what happened is that those who did not develop neither a blood clot nor cancer, they had this survival. So you can imagine this number as chances more likely to die. So this is called hazard ratio. So those who had blood clots, were having a blood clot is not necessarily a good thing. So that does mark for a higher morbidity and mortality even, as I mentioned. As we know, malignancy, some more than others, depending on how early or not early you catch it, it's potentially deadly. Indeed, one of the most common causes of death in the United States still. But if you have them both, you see a huge jump in likelihood of mortality. So first concept is that if you have them both, cancer-associated thrombosis, does isolate a patient who we as physicians have to be much more careful about. And then this little box over here, that's important. And actually,
Dr.
it's a
Chipper, I
title.
apologize to interrupt. I think the screen share turned off.
Oh, that's okay. Let me go back to screen share. You see it now?
Yes, we do. Thank you.
Okay.
It's just not full screen.
Were you guys able to see
Perfect.
the video then?
Oh, there it is. No, we did not.
Oh, I'm sorry. So yell at me whenever it happens. So this is what I was showing you before. And taking a visual, I think, is a bit more helpful than having an isolated storytelling. The cancer has evolved as to be able to grow by modifying the environment. And just like a Trojan horse, if there's a cancer cell covered by clot, my own clot, well, my immunological system will not be able to penetrate and stop it before it keeps on multiplying. So that, for example, is something that we know from platelet activity level and cancer progression. So, and that is partially the reason that we can definitely see a link between cancer progression and thrombosis and vice versa as well. So here, that's the risk rate that I was explaining before. So there's a huge jump if you are unlucky enough to have them both. And this box over here is what I was going into. Actually, that was the title of a study by Alok Khorana. Still, if patients who are followed with cancer, other than cancer progression itself, infections and thrombosis are the leading reasons for which we actually lose them. So it is interesting if we can try to go ahead and protect them from both. And we do have tools for that. Why is this an issue? So people would argue, and I've been told before, right before we did this study, and that's the reason we did it, we were told, well, you know what, they have the thrombosis as a consequence of, and therefore it does not mean that patients with thrombosis essentially do worse. So we tried to examine that question. Is it true that if you get a blood clot earlier in the disease, is that a marker of potential severity? Name it by delay in therapy, name it by complications of medications, because blood thinners can make you bleed, name it by the fact that you are a different patient just because this progression is being quicker. So we examined prospectively collected 727 patients with lung cancer specifically. And we defined early thrombosis, and this is an arbitrary measure, as within the first 3 months of diagnosis, plus minus. So clot that diagnosed a cancer or cancer that had an early clot. And those people, even after controlling for other potential problems, and when I say controlling, it means we mathematically eliminated the noise that those things were causing, patients who get early blood clots do actually have a more morbid progression in lung cancer. And the same has been proven in pancreatic cancer, actually. And a different way to see it is looking into how much does the disease progress depending on the cancer type. So you see the multiple colors here of cancer type and incidence, and then the likely incidence of blood clots, I mean, and then the probability of mortality of how lethal is that malignancy itself. So for instance, breast cancer, we often catch it early, is not globally a disease that neither clots nor actually is as lethal with considering all the denominator. Whereas in the other extreme, you see pancreas, and pancreas is the king on this. Both brain tumors or pancreatic are the ones who are most feared about blood clotting, whereas kind of in the middle tier, we have lung, gynecological, lower tiers, prostate, breast, which we see actually thrombosis in those malignancies, but that is a bit more of a virtue of very large denominator, not necessarily of causality directly. So let me move from why would I consider prevention to this actual information. So this is called an odds ratio. So I'm sure some people have bet something before, and then that's where the odds mathematics actually come from. But an odds or one would be me flipping a coin. So it can do face or it can do tail, and it can do one or the other. So it's one, it's equal. And if I say that it's closer to 0.5, means that I'm reducing the chances of clot to about half of what it would originally be. Okay, so the wording doesn't come exactly as that statistically, but that is pragmatically what I'm saying. When we did a meta-analysis, meaning we accumulated a lot of publications that were trying to prove this, those people who got a medication, specifically injections in the belly, versus those who didn't do anything, the ones who got a medication were half as likely of getting blood clots. Now, that half as likely is different depending on which kind of malignancy you have, because half of 1% is a not very exciting 0.5. Half of 20, 25%, well, then we're talking. I mean, then we're actually having a medication that can change and impact a lot of people if we are only so smart as to actually try to define who is at risk. So we looked at this one also. Then this one is essentially on only patients with lung cancer. And when we actually look in these odds ratios here, which whenever they actually don't cross the unit, essentially means that it was real, it was truth, statistically at least. There was even a shift towards likelihood of death in this specific type of tumor. Now, I'm not going to say that preventing people from blood clots is going to start saving life, because that has been tried many, many times and not achieved. But there was some light in this meta-analysis as to say that if we were to select the right person, we can try to do something for him. So Professor Alok Khorana is hands down the person who has studied this the most. And he made a prediction score. So again, I don't have a crystal ball that works. At most an 8-ball actually, and still is useless. So what we can do is not to predict the future, but to understand what has happened. And based on that, quantify and weigh risk factors. So what I mean with that is, out of a series of risk factors, we statistically measure which ones sort of correlate with having a blood clot in the future. And then there's some that are going to be more dangerous than others, right? So for those that are very dangerous, we give them a higher score, points. For those that are not so, we give them 0. And thus it was born this Khorana score. Very simple, because the database that he used, 4,000 people database, was actually very simple for these kind of variables, but makes it useful because it's easy to replicate at least. Now, it can always be improved upon, but this is the best we have right now to a great extent. And what it says is that patients with some kinds of cancer will be at higher risk, especially so when their pre-chemotherapy laboratories are high on platelets, low on hemoglobin, very high on leukocyte count, which is interesting. That also has other problems, or heavier weight. I mean, BMI is over 35, even though that variable specifically is a bit challenged. Other things that can actually help me predict. I did this with my best friend. He's an oncologist at Mayo Clinic and lung cancer specialist. What Aaron Mansfield did, essentially, we collected prospective studies from NIH, from NCI, National Cancer Institute. And we looked into level of liver dysfunction into saying, are these patients more likely or less likely to have blood clots? Well, it was an interesting question in our mind because the liver is also in charge of a lot of your coagulation structure. But to our surprise, to some extent, the worse the liver was, the more likely people were to clot. And in retrospect, you can explain things, right? So this has all now been found also in some prospective studies that people with metastatic liver disease actually tend to do worse, even on therapy, have a higher likelihood of clotting, because the liver is not only the one in charge with clotting proteins, but also anti-clotting proteins. So the liver is in charge of a little bit of both things. I did this, actually, this was my master's thesis. We collected patients right before chemotherapy, so they were naive to any other material exposure, took their blood and analyzed a series of biomarkers. Factor VIII, which is one of the many coagulation factors that we all have. If you've heard of hemophilia, that's factor VIII just when it's too low. Well, we collected the factor VIII, and if it was too high, or if your protein C, which is precisely the liver protein that actually is an anticoagulant, one of them, either of those two things was predictive of having blood clots. Now, the problem with all of these prediction scales, and height actually, interesting also is a factor. The problem with all of these prediction scales is that they're not unified into a single model. And trying to be very specific has its limitations. I was told this story once that there was this matchmaker. He had a company with matchmakers. And essentially, he wanted to make sure, absolutely certain, that all of his matches would work. Okay, so what he did was he started trying them, each one of them, so that he was sure that they will all work, actually, and they were all very useful. And the problem with that level of specificity is that you run out of sensitivity. So if you want to be so certain about the truth, you start running out of tools actually to be so assertive. So we need to compromise to being having an estimate. Now, this group, the Vienna Cats call themselves, got a nice evaluation. They studied prospectively many other variables, including von Willebrand, which is, can consider it a platelet activator. P-selectin, also from the platelets. Factor V Leiden is the most common genetic mutation in the United States that prompts you to clot. Other markers in TG, so meaning how fast the blood coagulates in a small dish. D-dimer. And this one is interesting because it's so easy to do and so much available in laboratories around the United States or anywhere, actually. And what D-dimer is imagine a spider web. So you get a spider web, and those little fibers actually are fibrin. So fibrin will be now in charge of getting little blood cells on top, like a butterfly or a fly, etc. And all of that thing now is a blood clot. Now, I invite you to imagine that you're grabbing that thing, and then you're left with this kind of dirt in your hands. Well, that's a D-dimer. So we're able to measure that dirt in your hands, so what is left over of fibrin. And by analogy, if your D-dimer is pretty high, well, that sort of means that has been some formation of that fibrin mesh. So chemically, at least, it means that you're clotting. So what this group did is actually they simplified things. Something simple is better. They simplified the type of cancer, so on low risk, high risk, or very high. And then they plotted the D-dimer to give us an estimation of how likely is this patient to have a blood clot in the next few months, 6 months. And then they validated that outside. And this metric is actually available online for calculation. It's a complex formula, so you do need a computer to do it for you. But it's another way to stratify the patients who might do better if we give them medication. Now, as I mentioned, the Corana score is the best we have right now. So 2 studies using a directional anticoagulant and another one, a smaller before with an injectable. used patients with a higher Coran score, 2 plus, and then they randomize them. So what I mean with that is I have 800 patients, 574 in this case, and then to half of them, which I don't know who they are, I'll give them a Pixaban, and to half of them, I don't know who they are, I'll give them nothing, which is what we usually do still, and just watch them. Well, what happened at the end of it is that the patients who got the drug were less likely to develop blood clots. Well, not surprised there, but it had to be proven. And it had to be proven that when we actually have a scoring scenario, we optimize our resources, because it wouldn't be wise to just know this and give a drug, potentially dangerous and very expensive drug, to everyone. But now we're learning a way to say who may be benefiting from this more. And that's when we have a conversation in which you tell me your values, I review what else is there outside of the Quran score, and then we have a conversation to make sure that this is within your risk management and it makes sense. And I'm happy to say that we actually started that process, and we're measuring how that is working in the gynecological cancer in North Shore. The patients who are about to receive chemotherapy are now being prospectively scored to at least start having the conversation, because regretfully, what you're hearing right now is not very popular. So even though clots happen in about 900,000 people per year in the United States, which to compare is actually more common than breast cancer, HIV, car accidents, all combined together per year, a lot of people have no idea what it is. So that's just the truth. Then Cassini did something similar. I participated on this trial. This one was, instead of apixaban, it used rivaroxaban. Long story short, similar consequence. The statistics were different. The design was a little bit different. I will not go deep into that. Just suffice it to say that the global idea was similar. Now, not everything is perfect, and this is really not an invitation to badmouth the Corona score as much, but just to be certain that the work is not yet finished, and we still need to learn more about how to stratify these people, these patients, and including patient-reported outcomes, including what they want and what they feel, starting a conversation rather than being mandating what to do. So what I did, well, actually was just a co-author on this, but essentially what we did is we measured a meta-analysis of how predictive would be the Corona score, and then there's patients who are left out. That's the message here. So I'll quiz a little bit. So anybody wants to share the most interesting thing that they heard in the last few minutes? Please go ahead. I mean, I'll open the chat box. I mean, you have it there. And then the question is, feel free to submit a one thing or two that was worthwhile. So was it perhaps that what is a blood clot? So a blood itself coagulates and can travel to places. Perhaps the concept that some types of cancer are worse than others. And probably the most encouraging that I've told you thus far is that if we know that you are at risk and we have a conversation, we're not empty-handed. We do have something to offer, okay? So I'll move to the next, because now we know that this can happen. Now let's go into what to do if. And if I go back in time, Jesus, 20 years ago almost, this was a clot trial, which for one reason or another, maybe because it was published in a much higher impact journal, it changed practice. So the only thing that we had back then to treat people with blood clots was warfarin, Coumadin. And then we would give them an anticoagulant, and then they would often fail. When you see this curve here, this is a curve that kind of measures percentage likelihood. And if I had a patient with cancer, both of them with blood clots, the chances of this one to get another blood clot on Coumadin was closer to 20% at follow-up, whereas this one was about half, and still that is actually a lot, I would say. So this was the difference that given the patient's injections in the belly, dalteparin specifically in this case, was able to prove. And it was so good that it made sense to start offering to patients Mrs. X or Miss Joe, I want you to please start injecting yourself for the next 6 months at least, which is not a nice thing to say, but there is a purpose. It was actually easier to control. The bleeding likelihood was not worse. And the chances of clotting, even though they were not good, they were much better. So what is curious is that they republished these in 2019 because they were trying to do a smaller specifics into which is the patient that benefits the most. And this happens at the same time that there were many other studies that were trying to prove this. And it's not the time or moment to actually go too deep into the details, but suffice it to say that there's no study that is perfect. And if I really go deep into any of the other studies, they were not purely positive for one reason or another. When I say purely positive, I say with big, bold capital letters, because it depends on how you were looking into. They were not purely positive for early reduction of recurrence rate of thromboembolism. And so much was the uncertainty that just a few years ago in 2015, Dr. Agnes Lee again and Alok Khurana did yet another study, the largest to that moment that has ever been done for comparing warfarin to a low molecular weight heparin, tinzaparin in that scenario. And what happened is that it made really no difference. So we do consider that it's better in selected scenarios, but saying blindly that it's better for all is not the message I want to give you. So from that thing, we're trying to give patients better options. And this is one of my favorite pictures. I actually even have a mask actually with the Hokusai thing here. And the reason I put it there is because my old mentor from Oklahoma did this trial, which was one of the largest to date, comparing not anymore warfarin, because we already kind of proved that that is not good enough, but it's going to compare injections in the belly, dalteparin, versus a direct oral anticoagulant. Now, what I mean with direct oral anticoagulant is medications that you take, and instead of Coumadin that has to travel to your liver, turn the vitamin K off, and then reduce your coagulation factors, these direct oral anticoagulants directly bind to one of your coagulation factors and then stops the likelihood of progression to clots. It's not complete, so the risk of bleeding is low on these agents because you can still bypass the system. Now, long story short, Hokusai was done with edoxaban. So it's a good medication, for good or for worse. It's not very popular in the United States. With Select D, which was done with rivaroxaban, which is Xarelto. You may have heard of it. I was participant of this landmark trial, which was the first one to use apixaban in a patient with cancer thrombosis. And then a Carvalho, which was the latest of the family, which again used apixaban, but in the distinct population, a wider population of cancer-associated thrombosis. Now, they all had differences. They all have different stories to tell. If we go deep into the trials, I can compare them differently. I have a different story to tell you, but let's stay with the main picture. And the main picture is that they're at least as good as giving you injections. And I would argue much easier. And they are not worse as far as bleeding in general. Again, if I go deeper into the which one and why, I do have a conversation with the patient to give them the pros and cons of one versus another, because we can find differences. But the big picture is that you do have an option. Okay, so now we have warfarin as an option, perhaps subideal, but sometimes the only choice. Injections in the belly, foolproof, and still the best choice for some, or direct oral anticoagulants, of which I have several families. Pragmatically, in the United States, I have 2 that have been well tested in this population. Now, there's this fallacy going around that direct oral anticoagulants have no interactions. Compared to warfarin, perhaps they have no interactions. But the truth is that they do have several. And then this conversation will have to touch base into what else are you taking so that these drugs don't combat to each other and can indeed be taken along. So third is the charm. I'll invite you again to find a little chat box. So let me actually say something on the chat here, and perhaps that's going to entice people to start talking. Or Sabina, you can invite him as well, because I would like to understand, as a patient, if I was a patient, and I haven't been a patient for this, but I do definitely like to hear and understand what your voice is. What of these was known if you ever had cancer? What of these is important on your decision making? So is it drug efficacy? Is it the unpleasant scenario of using injections? Is in the risk and legend that some people have that these newer drugs are too new, and if you have a bleed, there actually are there's nothing to do. And the reason I'm asking these rhetorical questions is because a lot of that is no longer true, actually, or never was. They're just things people say. These medications are very safe if you use them wisely. And as far as the unpleasant scenario of poking or no poking, uh, there's methods to transfer that. But at the end, what I like to say is that it's not about which medication. Uh, all of them are good or bad depending on what else is happening with the scenario, whether the cancer is early, whether the patient is post-operative, whether the absorption is normal, whether they have interactions, whether they're at the beginning or at the end of the journey. The options should be different. And how to predict? I told you I like to pretend I have a crystal ball. To educate the patients on those kind of choices, something else we looked into with the Riete database. So Riete is the largest repository of blood clotting patients or patients with blood clots. And specifically, we took about 12,000 of them with history of cancer and thrombosis. And the question at hand was, who is at worst risk of fatality? So, because that may actually change how aggressive I am. And then we found actually, and that's why I was trying to mention that if I was to actually ask these questions in order, is there any leukocytosis, meaning the white count is high at the moment they have the blood clot? Well, that's not a good thing. I actually need to ask no more. I already know that's not a good thing. And that puts him in this highest bar over here. If the answer is no, well, do they have metastases? And if the answer is no, they don't have metastases, I don't need to answer more questions. Actually, I know that they are low risk. And to split the people in the middle, I keep on asking a few questions as far as the place of the blood clot. Now, this is now internally and externally validated. What it means is that we took some of the patients in the Riete database and we retested our hypothesis, and it was true, meaning that people with no leukocytosis and no metastasis actually have a relatively low 30-day mortality. Relatively, I say, because 2.9 is not pleasant necessarily. Whereas those who have either leukocytosis or immobility, whereas metastatic, so terminal disease, that's a very high mortality, well over 25%. And that has been proven now in other repositories. There's an Asian repository that did the same. My colleague, and now just hired as a Mayo Clinic attending, actually, Harry, he did this as his master thesis, and we essentially proved it compared to transformed into an actual scoring system. So that's what I had to tell you. So if I'm into summarizing the main idea that I want to take home, or you to take home, is what is a blood clot? So blood clots can happen with cancer. And if they do happen, we have many options. And if they haven't happened, but you're at risk, we do have options too. It's just about making sure that you open the conversation so that these questions can be addressed. So I'll shut up and listen what we have to say.
One person left and said she just had a question but had to go. Is any lifestyle adjustments, physical, any things that they could do in addition to the medication to help?
That is a very frequent question, and I'll divide it on before and after clotting. So what is to be done on before? There's nothing I can offer you as far as food, kind of things that will actually alter the risk. There's some natural elements out there that do have coagulation changes, but they haven't been really tested as for me to tell you it should be done or not be done. But activity level is important. So stasis is one of the reasons people clot. And what I mean with stasis is this triangle, we call it the Virchow triangle. So if your blood is not moving, you clot. If your blood is inflamed or your vessel ruptured, you clot. And if you have something inside you, like cancer, that can make you clot, then you clot. So sometimes you need the whole triangle, sometimes you clot without the whole triangle. What after the clot? So imagine the blood clot actually happened in the leg. Well, your main pumping function in the veins is not the heart. The main pumping function from the legs is actually the calf function. So again, activity will help. And stressing your calves, using compression actually will help the calves mobilize blood better. That is actually tested to improve the flow. It's not tested to improve the risk of clotting, but it actually implies on part the recovery function. And if there has been a blood clot in the lungs, we do want to have progressive activity, but a little more coached. Some people, after having a blood clot in the lung, they have severe shortness of breath for quite a few weeks before they can go back to usual. The majority go back to usual, but not all, and that's yet one of the reasons we like to try to prevent whenever feasible.
Thank you very much, Dr. Tafur.
Sure thing.
If people have questions, feel free to submit them through the chat. And I want to know if you're submitting them, you can send them to everyone or send them directly to me, Sabina. And